So we're halfway through section 1.3. We'll try to finish it today and then also finish 1.4 today. 1.4 is pretty short. I probably will not use the PowerPoint for 1.4, and I'll just hit the highlights of the terms that you need to know. Okay? So before I get started, any questions over what we've done so far in 1.3? And really any of chapter 1. Is there anybody in here who still has not gotten set up on the Hawks learning system? Because there are still a few people that their name wasn't showing up in my roster on there, right? Everybody feels like they're good to go? All right. Any questions? All right, so you tell me, where did we leave off last time?
Voluntary response.
Voluntary response, okay. And what is a voluntary response sample? Okay, it's a non-random sample, and it's usually a survey of some kind. The main thing I want you to remember about, let me ask you, what is the main thing I want you to remember about voluntary response samples? They're horrible. Don't trust them. Don't do them, and don't trust the results, right? They're pretty useless. Okay, did I get to this slide last time? Okay. So this slide is an introduction to different types of observational studies. So in the book, you'll see a similar box, but I think it's purple, but similar box. It does not have case control study. Okay? So I added this. But you will be responsible for this term. I was very surprised, actually, when I read the book, and they didn't talk about case control studies. They are some of the most common types of observational studies that are out there. So I think it's important to see them. So first of all, a little bit of review. What's the difference between an observational study and an experiment?
Observationally, you just observe what is already there for you, and in an experiment, you can change the controls.
Okay, exactly. Very good. In an observational study, you're just observing what's already going on. In an experiment, the researcher controls who gets what treatment or what condition. Okay? So if it is an observational study, you can break it into, there's a few others, there's two more on the next slide, but these are the main three types of observational studies. The first one's called a cross-sectional study. So I think of cross-sectional, that term, you know what it means to say a cross-section. Have you heard of that term? They use it in biology a lot, or like in geology where they drill core samples or whatever. It's a cross-section. But think of it as a timeline, and a cross-section is a cross of that timeline. It's like at this point in time, this is what's going on. That's a cross-sectional study. And most surveys are cross-sectional studies. All right? So at one particular point in time, you give a questionnaire and you say, do you have these conditions? What kind of exposures do you have? And you're looking to see if there's any association between those things. So it's a single point in time is a cross-sectional study. All right? So the next one is a longitudinal study. And a longitudinal study is across time. This is a prospective type of study. What does that word mean, prospective? Okay, this is an English class, so break it down. What's the root spect mean? You're wearing spectacles. That's kind of an old term, but what does it mean? To see or to view, right? So pro, Well, pro as opposed to retro, right? In the future, right? So prospective, you proceed, right? So prospective is to look ahead, right? So a prospective study follows subjects through time. A specific type of longitudinal study is a cohort study. And cohort studies are commonly done where they'll recruit at the beginning of some period of time people who they know don't have a particular disease and they know they don't have a particular exposure. Suppose I was interested in cigarette smoking and lung cancer. We talked about this last time, right? I might recruit a bunch of 6th graders to enter my study because I figured none of them have started smoking yet. At least we hope not. And none of them should have lung cancer yet. Now I'm going to follow them for 50 years. That's a longitudinal prospective study. You're going to follow them through time. You'll see which ones decide to start smoking, and of those, which ones get lung cancer. So the ones that don't decide to start smoking, you look at the lung cancer rate 50 years from now in that group compared to the lung cancer rate in the group that did start smoking. That's a longitudinal cohort study. This one, which is not in the book, is a retrospective study. So what does retrospective mean? Looking back. Retro, right? So looking back, i.e. a case control study. This is the most common type of a retrospective study. So the definition's written up here. In a case control study, data are collected on past exposures, and an exposure could be anything. It could be smoking, it could be exercise, it could be exposure to benzene in the workplace, it could be your mother smoked when she was pregnant with you, anything in the past, right? And you divide, or you recruit into the study 2 distinct groups. One are the cases. And these are people that are known to have the disease. So if I'm trying to study lung cancer and smoking, then I might go to 5 different hospitals and say, okay, when a patient comes in and gets diagnosed with lung cancer, let me know and I'm going to enroll them in my trial. So those are cases. We know they have the disease. And then at the same hospitals, you recruit a control group. I want some people who come in and get diagnosed with something else, but it's not lung cancer, like they have, diabetes or something like that, or just and you try to do it. The best kind of study, you do it in a matched way. So you maybe age match them, gender match them, race match them, whatever variables you think might be important. Then when you have your cases and your controls identified, now you question them about their past. In the past, have you ever been a smoker? How much did you smoke? That kind of thing. And then you compare the lung cancer, I started to say you compare the lung cancer rate, but you've set that rate by how many you recruited because you intentionally picked people with lung cancer. So now you say, okay, in the lung cancer group, what % of them were smokers? And in the control group, what % of them were smokers? If there is a relationship between smoking and lung cancer, what would you expect to see? Hello?
Can you say that again?
Now remember, I'm going to take my smokers, I'm going to take my lung cancer patients, and I'm going to compute the % of them that smoked in the past. And then I'm going to take my control group, and I'm going to compute the same percentage. What % of them smoked in the past? If there is a relationship between smoking and lung cancer, what would you expect to see? The % who were past smokers is greater in the in the lung cancer group, in the cases, right? So in the cases, you expect a higher rate of the exposure than in the controls. If you don't see that, then you have evidence that, well, there's really not any relationship here. Okay? So case control studies are very common. They are excellent at getting at rare diseases. If I do a cohort study for lung cancer and smoking, and I recruit these 6th graders, what do you think the lung cancer rate is among smokers? I actually don't know. I should have looked it up, but I didn't. But it isn't real high. It's like 15% of them. So in my study, to get any cases of lung cancer, I'm going to have to look at a huge sample size to get very many lung cancer cases. Whereas in a case control study, you're finding people who already have the disease and you just recruit that many. They're easier to get that way. Okay? All right, let's look at this example. Classifying studies. So Part A says a group of 220 patients is followed for 15 years in order to determine the long-term health effects resulting in gastric bypass surgery. That's a longitudinal study. They're going to follow them through time. A gastroenterologist surveys 130 of his patients 6 months after having gastric bypass surgery to determine the average amount of weight loss. He definitely has cases, 130 of his patients who had this surgery, but what about controls? There's no controls. And he's just looking at one point in time, 6 months after surgery, what's the average weight lost? That's a cross-sectional study, right? And then this one is going to be, guess what? Case control without reading it, but here we go. To assess whether cell phones increase the risk of brain cancer, researchers determine I left the word "the" out, determine the amount of cell phone use in recently diagnosed brain cancer patients as well as age-matched healthy subjects. That's a case control study, right? And brain cancer is far more rare than lung cancer, so it would be about impossible to do that study as a longitudinal study. Okay, so we went through the solution. These two terms are kind of at the opposite extremes. The top one is called a meta-analysis. This is it's sort of a type of observational study. Well, I guess it is because you're using data that's already collected. I actually have published quite a few meta-analyses myself, and they are combining the results from past studies. So in a lot of disease states, you might have, some physician that published a paper about 6 patients that she had, right? And then somebody else had 23 patients. But all of those studies were too small to draw any real conclusions from. But you put them all together, now you got 300 patients, and you can start to see some signal through the noise. So that's called a meta-analysis. Compiles information from previous studies. And then a case study is a single event. All right, the example that they use in the book for a case study is about a tsunami, and they study all of the things that happened after that tsunami, but it's one case. And then they try to apply it. If a tsunami occurs, this is what's likely to happen, this is what's going to happen, right? But in the medical world, a case study is a single patient. In the New England Journal of Medicine, one of America's top medical journals, always has at least one in every issue, and it starts off, the title says, a case study, a 44-year-old white male comes in with blah, 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 and we did this, and it worked. That's a case study, okay, a single observation. You put a bunch of case studies together, go find a matched control, and you got a case control study. Okay, so those are observational studies. Now let's talk about experiments. So experiments, we said a while ago, experiments are studies where the researcher assigns the treatments to the subjects. Well, just like everything in science, there are good ways and there are bad ways to conduct experiments. There's good ones and there's bad ones. So you still, even though it's an experiment, doesn't necessarily mean it's good. All right? So we talked about what a treatment was. That's the first thing up here. And by the way, I'm looking around, I'm seeing everybody scribbling, trying to hurry and get this down before I hit page down. This box is in your book, so you can fill it all in. You might just hit the highlights. You can go back and get them later. Right? We've talked about what subjects are. Subjects might be people, they might be dogs, they might be tubes of toothpaste. Whatever it is you're interested in, a subject is one of those. Response variable and explanatory variable. All experiments will have something that you can define as the response variable and something you can define as the explanatory variable. Most observational studies will also have those things, but not always. You might not have an explanatory variable. Any questions on that? We've talked about all these terms before, but... Okay, so let's talk about how to design an experiment so that it is as valid as it can be. The first bullet up there says randomize the control and the treatment groups. Actually, before I get to that, I'm going to... I can't remember if last time I defined what we mean by control group. By now, I've said it enough times, you should have a good sense of it. But in an experiment, it's really important to figure out, well, what is my control group? And what's the best way to treat that control group? So what do we mean by control group? What did you say? Okay, good. A group of subjects that don't receive the treatment. And again, remember that word treatment is a generic word. It doesn't necessarily mean a drug or something, but they don't get the treatment. All right? So here's a little quick example. Have you guys heard of the drug Allegra? Heard of that? It's an allergy drug. And I was actually the statistician that worked on the clinical trials for Allegra. Came out of Kansas City. Right? So you should use it. It's a local product. Not anymore. It's in France now or something. I don't know. Anyway, suppose I want to study allergies. So I need to get some patients. So I go out and I recruit 200 patients who have allergies, and I have them rate their allergy symptoms. None, mild, moderate, severe. And then I send them home with a bottle of Allegra. And I bring them back in a week, and I say, okay, now rate your symptoms. And lo and behold, sure enough, their baseline disease severity was much worse, noticeably worse, than a week later. They all improved, or at least on average, they improved. What have I proven? What kind of claim can I make based on that study? Can I say Allegra works?
There's the option, like, there's a chance that it might work.
Okay. I actually can't even say something like that. I can't put a probability to it based on that study. What's wrong with that study? There's no control group. How many people have seasonal allergies? It's been a good week, hasn't it? What can happen in a week's time that changes your allergy symptoms? What'd you say? The weather changes. And if the weather changes, maybe the pollen count drops. So I send them home with this bottle of Allegra. The pollen counts happen to drop at the same time. They come back a week later, and sure enough, they're better. I haven't proven Allegra has any effect at all. All I've proven is that this group of patients were better a week later than they were now. But if I add a control group in there, then I can say, well, look, the Allegra group dropped, the control group didn't. And they were getting the same environment as the other. So they're treated the same in every way except the Allegra. Now you got something. So you have to have a control group, right? Now, the first bullet here says randomize the control and the treatment groups. First of all, do you know what it means to randomize?
Have a random sample.
Say it again.
Have a random sample.
Actually, it does not mean that. What she said was it means you need a random sample, right? But clinical trials rarely ever have random samples. What we take are patients that come in and say, sure, I'll be in your clinical trial, right? They're not a random sample of the population. But what we do, we get randomization into it by randomizing the treatment. So in the simplest case, and again, it's not really done this way, but we do it with a computer, but patient comes in and I say, oh, I need to randomize you to treatment. Heads, you're on active. Tails, you're on placebo. Oh, congratulations, you got placebo. Right? That's randomization. So the physician does not decide the treatment. The computer does. Or your coin. It's done randomly so that nothing can be influenced. Why would that matter? Why would it matter that it has to be done by the computer and not by the person that's going to treat the subject?
Because they know they could tell them like things that
Okay? They could subconsciously even let them know which treatment they got, right? And we're going to get more to that effect in just a minute. But also, think about a clinical trial for a more serious type illness than allergies. Not that that isn't bad enough, but something where maybe something like Parkinson's disease, where you know they're going to decline over time. But if you get them on medication, you can make that decline slower, right? And I'm a treating physician, and I have a patient that comes in that's really, really severe. Their disease is pretty bad already. If I get to choose whether they're in the placebo group or the active group, then I may say, I'd really rather see them on the active medication because they can't wait. But somebody else comes in and they just got diagnosed, they're not very severe yet, well, they can handle placebo for a couple of months, and then we'll switch them over to the active medication when the trial's over. That's bias, right? Now you've made it harder for your drug to show an effect because you put all the bad patients on active drug, you put all the mild patients on placebo. Now you're not going to be able to show a difference, right? So this is what we mean by randomization, or what randomization accomplishes. But randomization controls for selection bias. So selection bias, meaning bias in the way that patients are selected to be on each of the two treatments. But randomization does another thing for you. It's sort of an added bonus. It also helps balance for confounding variables. Even variables that the researchers didn't think about, randomization will tend to put half of them in one group and half in another group. So if smoking affects the way that the drug works, you'll tend to get half your smokers in one group and half your smokers in the other group. Whereas if you let the researchers decide who goes in, they may not get that balanced. They may subconsciously put all the smokers in the active group and all the non-smokers in the placebo group. Right? So randomization is key to a good experiment. Okay? Then number 2 says control for outside effects on the response variable. So that's the things like smoking or gender or anything like that that could be an important confounding variable. You try to control those things as much as possible. We talked about the cholesterol experiment last time and getting the people that ate at McDonald's. I wasn't controlling for diet. So a good experiment would control for their diet, which is a confounding variable. Replicate the experiment a significant number of times to see meaningful patterns. So replicate. That's, when they use the term here, they're talking about each subject is a replicate. So basically you need a big sample size. That's what they're saying. They don't mean run the experiment, analyze the data, get your results, and then now I got to go do the experiment again just to show that I get the same results. That's not what they mean by replicating. It's not replicating the entire study, but each time you give a subject a treatment, that's an experiment on that subject. Now replicate that. Okay? I can't recruit one placebo subject and one Allegra subject and prove anything. I need more evidence than that. I said all that already. So let's talk about placebo and the placebo effect. I've been shooting that word around, placebo, but I haven't really defined it yet, so here you go. Has everybody heard of placebo? Placebo is, what is placebo? Don't just read that. But when you think the word placebo, what do you think of? Okay, it's a fake pill. Nobody said it. Usually somebody says it's a sugar pill. It's actually not a sugar pill, but you'll hear that said in the media, right? You'll see these commercials on TV for prescription medication, and they'll say, they'll read this laundry list of horrible things that this drug could do to you, right? And then they'll say, but incidence was similar to sugar pill. Well, they mean placebo, and it's not a sugar pill. It's a substance that appears identical to the actual treatment but contains no intrinsic beneficial elements. So the way I say it is it looks, tastes, and smells exactly like the real drug. All right? Why do you think that is? If it tasted like sugar, they're going to pretty much know they're in the placebo group, right? My mother was in the tamoxifen breast cancer study, which tamoxifen is a breast cancer prevention thing, right? And she was at the site at KU Med. And I was actually working at KU Med at the time. I wasn't working on that trial, but I was at KU Med. And she stopped into my office after her appointment, her first appointment. And she said, hey, I got in the active treatment group. Because by informed consent, you have to tell the patients there's a 50% chance you're going to be on placebo, 50% chance you're going to be on active, or whatever the percent is, right? I got in the active group. I'm not in the placebo group. And I thought, oh, crap, they told you? It's supposed to be a blinded study. Somebody didn't do their job. I said, how do you know that? And she said, because I bit the pill. And it tasted like crap. It was horrible. So I know it's not the sugar pill. So, I'm a statistician. I've worked in the pharmaceutical industry. I said, oh, good. Because if she believes she's on the active drug, she's a better patient, right? She is experiencing the placebo effect, if there is one, right? And you want that. So what is placebo effect? What does that mean? The effect of placebo. How could something that has no beneficial elements in it be effective? How could it have an effect?
Because the individual believes that it is the medicine.
Exactly. It's psychological, right? If the brain believes that it's getting something that's going to help, a lot of times it actually does help. It's strange, and for a long time it was sort of poo-pooed, but they've actually done a lot of studies on it now and realized that there are actually chemical changes in the brain when you start to believe something, and it actually can improve the disease. Right? So just belief that you're getting help. Yeah.
So is the placebo effect actually good for like a subject, or can it like affect the study?
It can certainly affect the study. Placebo effect is an effect, so it's helping the subject, right? Unfortunately, placebo effect usually wears off with time, but it is a benefit to the subject, but it can ruin a clinical trial, right? Think about my Allegra study. Okay, so now I know, I need a control group. So I send one group home with a bottle of Allegra pills, and the other group I send home with nothing. Right? So allergy symptoms, let's say down is good, so symptoms went away. And so I have a baseline period, and both groups are roughly the same. Then I send them home for a week, and the Allegra group drops down to there. And the other group is there. But I didn't give this group placebo. So this difference is not the treatment effect. What is it? It's treatment plus placebo, and I have no idea how much of each there is. It might all be placebo effect. It might none of it be placebo effect. I can't tell. It's confounded. But if I give this group placebo, and they drop some, but not as much, this difference is the true treatment effect. This difference is the placebo effect. Now I can separate them. Right? So this is placebo effect. This is treatment effect. And the whole drop is sum of the two. So if you don't give placebo, if you don't treat your control subjects, then you can't separate out placebo effect from real effect. So in order to have a quality study, you need to give placebo. Now, we hinted at blinding a minute ago. There's actually 3 levels of blinding. The book only talks about 2 levels. The first one is no blinding, but it bears using because it's commonly done. So 3 levels of blinding. The first one is no blinding, which we call open label. So you give them a bottle of pills, and it says right on the label what it is. So we call that open label. No blinding. Some trials are done as open label studies, particularly life-threatening diseases like oncology, cancer studies. The physicians and the patients are not willing to take something they don't know what it is. And you can imagine, they might have 6 months to live if they're untreated. They want to know what they're getting. So you do them as open label studies. And it's always open label, new medication versus standard of care if they weren't in this study. What would they be getting if they weren't in this study? So it's open label, right? But it opens the door for certain amounts of bias to creep in. The second one is called single blind. And you can read up there what single blind means. It means that the subjects don't know which treatment they got, but the researchers do. So the people conducting the study know what they're getting. Right? That's not as good as double blind. Double blind is when neither the people treating the subject or the subjects know what they're getting. Why would you not want the people treating them to know?
Researcher bias.
Okay, researcher bias. And what does that mean, researcher bias? Was it you that said it? Okay. What does it mean?
They know one person is getting the treatment, the other one's not.
Okay. It can happen in 2 different ways. Go ahead.
They may favor some of the people that are experimenting.
Okay, they may favor them. In terms of what? In the way they assess the response variable, or okay? Okay, in interactions with the patients. And it's hard to convince clinicians that they are guilty of this. But they are, right? Just subconsciously, they might ask the question in a little bit different way. You know, how are your symptoms today? Seems pretty benign, but if I know they got placebo, I might ask it in a way that implies they really shouldn't be any better because you didn't get anything. Whereas the other group, I might say it is, so how are your symptoms today? You've been on this med for a while now. You should be seeing some effect. Right? Oh, yeah, I think I am. And, right? So they could bias it. So particularly if it's a subjective measure of some kind, please rate your symptoms, then you really need it to be blinded. If it's blood you're drawing and then some lab chemist is checking to see how much of some chemical is in the blood, you're not going to get much bias there, even if the treating physician knows what group they were in. But so there's some judgment. But single-blind studies aren't quite as good as double-blind studies, just because of the potential that there could be bias in the study. Okay, this is a study that we talked about a little bit before, but not quite as detailed. So let's go back through this. I'm not going to read every word, but this is that example that we talked about with the neurologist and vitamin C and the pain disorder. Remember that? And it says, or a nerve disorder. Let's suppose that they're focusing on a particular nerve disorder, multiple sclerosis. Right? So we got MS patients. And after the study, the neurologists solicit volunteers, after study approval, the neurologists solicit volunteers who are patients with MS who are reporting nerve pain. The participants are then randomly assigned to two groups, each having 20 participants. Okay? So what do we got so far? We've got a control group and an active medication group, and we're randomly assigning. So far, so good. Those are good things. All right, next page. Participants in Group A are administered intravenous doses of vitamin C, and they track their nerve pain. Group B got intravenous doses of saline, which has no active ingredients, i.e. a placebo. Right? So they get fluids into a vein, it just doesn't have any vitamin C in it. But they don't know that. Right? The patients are not told which of the two groups they're in. However, the nurses administering the IVs are aware of group assignments. After a certain amount of time, they rate their symptoms of nerve pain. This could be typical of a test question where I have you read a paragraph like that and then say, answer these questions. Identify the explanatory and the response variable. I think we already did that for this study last time. But what is the explanatory variable? What's that? Vitamin C. So whether they got the vitamin C or not. Right? And the response variable? What'd you say? No, that's not the response variable. Think about that word response. How do you want the patients to respond? Right, that's their pain level. So the response variable is how do they respond? How does their pain respond to whether or not they got vitamin C? Right, so that's the response variable. What is the treatment? Vitamin C or not, that's the treatment. Which group is the treatment group and which is the control group? Well, you have to remember which were they called A and which they called B, but that's what they're after. So group A was the treatment group, group B got the placebo. What's the purpose of administering saline to group B? Okay, by measuring, being able to measure the placebo effect, right? So we can't assess the effect of vitamin C without knowing how much placebo effect there is. Right? So that takes that out. Is this single blind or double blind? Single blind because the nurses treating them knew. And do you think that's the best choice for this study?
No.
Probably not. Why not? Because it's a subjective measure. Please rate your nerve pain. So the nurses could influence the way they answer that question if they know what treatment they're on. Right? There are times in studies where the medical professionals treating the subject actually assess their symptoms as well. We call them physician's assessment. You know, how do you think your patient is doing? And then you really don't want them knowing what treatment they got. Very obvious bias. And the last thing out of this section, I won't spend any time on it, but basically they're saying if you want to conduct research, particularly research on humans, then you're going to have to do both of these things. An IRB, Institutional Review Board, is a group that has no vested interest in the outcome of the study, and they read everything, the protocol and all that, and decide, yeah, this is a safe thing to do to humans. We'll allow it. Right? So every research institution has an IRB, including Washburn University. We do research, so we have an IRB that looks over every... And even as a student, if you want to do research in your psych class or whatever, you're going to have to get approval by the IRB to do that. Most of the things that students do, they look at and go, well, there's no potential for harm here. Right? All you're doing is asking them questions about, you know, their feelings on stuff. You're not going to hurt them. Informed consent, I talked about that when my mom was in that trial. The informed consent is a big, long document that they have to sign and say, okay, I understand what's going to happen to me here. All right. Okay, any questions about any of this stuff? That finishes up section 1.3. Yeah.
Okay, so like if the subject knows about the experiment, can they talk to other people about it, or would that affect the study?
Well, that's a great question. She said if the patients talk amongst themselves about the study, would that ruin the study? And it can, but that's why you try to make everything as blinded as possible, right? Placebo needs to look, taste, and smell just like the real drug, because the patients do talk, right? The patients are going to talk to each other, and if they say, hey, my pill's yellow, mine's white. Huh, well, I guess we're in different groups. And then they'll start talking about, what side effects have you had? Have you noticed any change? And so you want to control all that as best as you can. Right? But yeah, it can be a real problem. Okay, so the last section, I only have about 5 minutes left, but the fourth section of the chapter 1 is how to critique a published study. And I guess I will, since I don't have a lot of time, I'm going to go ahead and pull up the PowerPoint presentation for this, and we'll hit the highlights. Okay, so the first thing is when you read, and a lot of this really applies most strongly to the popular media. So if you're reading the Huffington Post on the web, or you're reading the Topeka Capital Journal, or watching the news, those are media reports about studies that have been done. If you're reading a scientific journal article, then those are what's called peer-reviewed. Do you know what that means? Peer-reviewed means there are other researchers that read it and say, you can't say that, or you know, this study was not good, or this study was good, right? So you can trust those peer-reviewed journal articles a lot more than popular media. So consider the source. As you listen to sound bites, ask yourselves these questions: who paid for that study? Right? If you hear of a great study that showed that you know, using this new floor polish and you get way better results, you know, who paid for that study? It's probably the company that makes the floor polish, right? So where were the data collected? When was the information collected? You know, how old is it? And who published the study? Was it in a scientific journal, or was it in, you know, somebody's blog, you know, So consider the source. As a statistician, you kind of get trained to just automatically think of all the words that they use, like top 10 things to make you happy. New survey. Read the results of this survey. What does happy mean? How do you measure happy? Well, obviously there's going to be a questionnaire, and so I want to see the questions that they answered to decide whether they were happy, right? So delve into it a little bit more. Read the fine print of the study to see how they define things like best and happy and things like that. I like this one. Not this one. That one. Makes hair 60% smoother. Smoother than what? Than it was before? How did they measure that? Under what conditions? What types of hair were tested? What type of weather was it when it got tested? Is your hair different on certain days than others? I've heard of that effect. The bad hair day effect. Right? Did they take that into account? So consider all of the sources that go into it. What variable is the study actually measuring? People make big, broad, global claims, but if you look at what did they actually collect, it's very small and specific compared to the broad claim they're trying to make. Yeah?
So, like, if they do all of this, if you ask them those questions, are they supposed to answer you honestly?
You mean, well, if somebody calls you and wants you to be in their survey? I can tell you that as a statistician, once in a while, I will say, sure, I'll take your survey, but I need to ask you some questions too. I'm a smart aleck. And the person on the other end of the line has no idea. They're just a paid telemarketer, basically, right? They don't know anything about it. So if you contact the company doing the study, then yeah, if it's quality of any kind, then yeah, they will let you know those things. If they don't want to tell you those things, then you know it's just junk. It's not a good study. Okay, that's all the time we have. So there's a few things that I didn't get to in 1.4. So you'll be responsible just to read the rest of that section. It's a pretty short section. So and so the homework over 1.3 and 1.4 will both be due on Wednesday. See you then.